Do you remember the MCV that defines microcytic anemia? I sure hope so. Don't disappoint me. Make sure you're using your book. Everything you need to know is in there. Again, my name's Dr. Anthony Wheeler. I'm going to tell you everything that you need to know about pathology. Every single thing. In this talk, we're going to be discussing microcytic anemia. This is the book that you need. Make sure you're using it. Don't be a procrastinator. Microcytic anemia. Anemia with an MCV defined by less than 80 femtoliters per meter cubed. Microcytic anemias are due to decreased production of hemoglobin. Red blood cell progenitor cells, which are called erythroblasts, in the bone marrow are large and normally divide multiple times to produce smaller, mature cells with an MCV that is normally between 80 to 100 micrometers cubed. An additional division that takes place to maintain hemoglobin concentration is what causes microcytosis. Heme, which is formed of iron and protoporphyrin and globin, combine to form hemoglobin. Microcytic anemia is caused by a reduction in any of these components, whether it be iron, protoporphyrin, or globin. Some common examples of microcytic anemias include iron deficiency anemia, chronic disease-related anemia, sideroblastic anemia, and the various thalassemias. We're going to talk all about those. In iron deficiency anemia, insufficient levels of iron cause iron deficiency anemia. Makes sense? To the right, we can see that iron deficiency anemia in a blood smear. Iron deficiency anemia is the most common type of anemia. A third of the world's population suffers from iron insufficiency. Sources of iron include heme or meat-derived sources, as well as non-heme or vegetable-derived sources like kale, dark leafy green vegetables. Iron is absorbed in the small intestine, mainly the duodenum. The heme form of iron is more easily absorbed than the non-heme sources of iron, i.e. heme in meat is more easy to absorb than heme from kale. Enterocytes in the intestine, small intestine, have both heme and non-heme divalent metal transporters, DMTI. Transferrin carries iron in the blood to the liver and bone marrow macrophages for storage, whereas ferroportin helps enterocytes move iron across the cell membrane into the circulation. Because stored intracellular iron is linked to ferritin, it cannot undergo the Fenton reaction and produce free radicals. Some laboratory measurements of iron status include serum iron, transferrin, total iron binding capacity, percent saturation, and ferritin. Iron in the blood is measured by serum iron. The transferrin molecule binds iron. Total iron binding capacity is the capacity for transferrin to bind iron. Percent saturation is the proportion of transferrin molecules that are iron bound. Ferritin reflects iron stores in macrophages and the liver. Now, dietary deficiencies or blood loss are the usual causes of iron deficiency. Infants may be iron deficient because breast milk is low in iron. Typically, children's diets are iron poor. Peptic ulcer disease in men and menorrhagia in pregnancy in women in adult age 20 to 50 are risk factors. Iron deficiency is brought on in older persons who have colon polyps or cancer, which is common in America. To the right, we see a peripheral blood smear of a patient with iron deficiency anemia. We can see that because there is so much central pallor. By central pallor, I'm referring to the white space in the red blood cells. In the developing world, hookworm, also known as Ancylostoma duodenale and Necator americanus, may be associated with iron deficiency. Malnutrition, poor absorption, and gastrectomy are further risk factors for iron deficiency. And this image to the right points out various findings in a peripheral blood smear, signifying changes attributed to iron deficiency anemia, such as hypochromic red blood cells or target-shaped red blood cells, microcytic red blood cells even. By preserving the Fe2+ form, which is easier to absorb than the Fe3+, acid promotes iron absorption. Now, there are stages of iron deficiency, and those stages include storage iron depletion, then serum iron depletion, and finally normocytic anemia. Normocytic anemia occurs when the bone marrow produces fewer but normal-sized red blood cells. Microcytic hypochromic anemia occurs when the bone marrow produces smaller and fewer red blood cells. Clinical features of iron deficiency include anemia, koilonychia, or pitted nails, or even pica. If your patient is eating dirt, you might want to work them up for iron deficiency. Iron deficiency anemia is treated by addressing the underlying cause and iron supplementation. Plumber-Vinson Syndrome is a condition that is caused by chronic iron deficiency. Plumber-Vinson Syndrome is characterized by anemia, dysphagia, beefy red tongue, esophageal web, atrophic glossitis. This image to the right is a barium esophagram showing cervical esophageal web in a patient with Plumber-Vinson syndrome. In Plumber-Vinson syndrome, there's this web-like growth of membranes in the esophagus that can make swallowing difficult. In fact, Plumber-Vinson syndrome may increase the risk of esophageal cancer. Now let's talk about anemia of chronic disease. Anemia of chronic disease is anemia due to diseases or disorders. Here we have a peripheral blood smear that's showing spherocytes or spherocytosis with that black arrow. Note the lack of central pallor. And reticulocytes, look at the red arrow. Note that sort of bluish hue. You can see that in the reticulocytes. As well as microcytic hypochromic red blood cells due to the anemia. And this is a patient that had autoimmune hemolytic anemia and Crohn's disease. Now, examples of chronic diseases that can cause anemia or chronic diseases include endocarditis, autoimmune disorders, and cancer. Endocarditis, autoimmune disorders, and cancer. Anemia of chronic disease is regarded as the anemia that people in hospitals experience the most frequently. The liver produces acute phase reactants such as hepcidin as a result of chronic illness. This hepcidin limits the transfer of iron from the macrophages to the erythroid precursors in the bone marrow and inhibits the formation of erythropoietin, which sequesters iron in storage sites. Hepcidin hides iron from bacteria so that the bacteria die. In chronic diseases, the body thinks bacteria are around running amok, which is why hepcidin is released, takes up the iron from circulation, and causes anemia of chronic disease. Laboratory findings in anemia of chronic disease include increased ferritin, decreased total iron binding capacity, the serum iron would be decreased, and percent saturation would be decreased, and the free erythrocyte protoporphyrin is increased. The underlying reason must be addressed during treatment of anemia of chronic disease. A particular group of patients, particularly those with cancer, benefit from exogenous erythropoietin. Now, sideroblastic anemia. Sideroblastic anemia is a very rare blood disorder characterized by hemoglobin deficient red blood cells. This image to the right is a very, very high magnification of a central red blood cell precursor, also known as an erythrocyte. But note that there is this blue crystalline granular rim around the erythrocyte. That's iron circulating the entire nucleus of the erythrocyte. That's sideroblastic anemia. Technically, if there are 5 granules occupying at least 1/3 the circumference of the erythrocyte, that's technically a ringed sideroblast. Now, there are numerous conditions that can cause sideroblastic anemia, which include classically lead poisoning, as well as alcoholism, and there are a few more that we will discuss. With regards to sideroblastic anemia, protoporphyrin is generated by a sequence of processes, and the protoporphyrin synthesis is deficient in sideroblastic anemia. Using vitamin B6 as a cofactor, aminolevulinic acid synthetase transforms succinyl-CoA to aminolevulinic acid in a rate-limiting step. Aminolevulinic acid dehydrogenase, on the other hand, converts aminolevulinic acid into porphobilinogen. Porphobilinogen undergoes further processes that result in protoporphyrin. Then, protoporphyrin is joined to iron by the enzyme ferrochelatase to produce heme, right? Don't we love biochemistry? Fascinating. In the powerhouse of the cell, the mitochondria, the last reaction takes place. Heme is then formed when iron enters the mitochondria after being transported to erythroid precursors. In the absence of protoporphyrin, the iron gets trapped in the mitochondria, and a ring of iron-rich mitochondria surrounds the nucleus of erythroid precursors. The word sideroblastic anemia comes from these cells, which are known as ringed sideroblasts. Now, both the congenital and acquired sideroblastic forms of sideroblastic anemia exist. Aminolevulinic acid synthetase deficiency is the most common cause of congenital sideroblastic anemia. Acquired causes of sideroblastic anemia include lead poisoning, right? I know you've seen those classic vignettes of a young child eating paint in an old house made in the 50s. The house was painted in the 50s or something like that. Or they're getting toys from a country with somewhat not high level practices on how the toys are manufactured. Like there's lead on the toys, right? Lead poisoning. Other causes of sideroblastic anemia include alcoholism, even B6 deficiency can do it, as well as isoniazid treatment, like in patients that have tuberculosis. Lead poisoning inhibits ferrochelatase and aminolevulinic acid dehydrogenase. Alcoholism itself results in mitochondrial poisoning. Aminolevulinic acid synthetase requires vitamin B6 as a cofactor, and vitamin B6 deficiency is most frequently observed as a side effect of the isoniazid treatment for tuberculosis. It's all tying together. Do you see any ringed sideroblasts in this image here? There's at least 3. Point them out. If you can point them out, I'll be proud of you. Good job. Now, laboratory findings of sideroblastic anemia include increased ferritin, total iron binding capacity, increased serum iron, and increased percent saturation. Thalassemia is a big topic, so make sure you're paying attention. Thalassemia is a red blood cell disorder caused by decreased synthesis of globin chains, which are needed to make hemoglobin. Reduced production of the globin chains results in decreased hemoglobin, which causes microcytic anemia. Thalassemia patients and carriers of thalassemia genes are protected from Plasmodium falciparum malaria due to a hereditary mutation. Now, there are 2 main groups of thalassemia that we're going to discuss: alpha thalassemia and beta thalassemia. Alpha thalassemia is due to gene deletions. Normal types of hemoglobin are hemoglobin F, hemoglobin A, and hemoglobin A2. Gene deletion is typically the cause of alpha thalassemia. You're going to need to know this chromosome. It's 16. On chromosome 16, there are 4 alpha genes that are often found under normal circumstances. 1 gene deletion is not a big deal, not a big problem at all, but patients will be asymptomatic, which is great. 2 gene deletions cause a mild anemia with slightly increased red blood cell count. Now, cis would be both on the same chromosome, and that's worse than the trans deletion. Asians commonly experience cis deletions, in this disorder. Trans deletions would be on different chromosomes, which is better than the cis deletion. You must know that. Now, Africans or people of African descent commonly experience trans deletions. 3 gene deletions cause a severe anemia that produces tetramers of beta, resulting in hemoglobin H that harm red blood cells. An electrophoresis reveals the hemoglobin H. And unfortunately, Hydrops Fetalis occurs when there are 4 genes that are removed. Red blood cell damage is caused by gamma chains forming tetramers, leading to hemoglobin BARTs, which may be detected on electrophoresis. Hydrops Fetalis is incompatible with life. Now, let's move on to beta thalassemia. Beta thalassemia is due to gene mutations. People most commonly at risk for beta thalassemia include Africans or of African descent and people from the Mediterranean. You need to know that the beta gene is on chromosome 11. Chromosome 11 contains the genes for beta. Now, the chain is produced less with beta plus or not at all with beta 0 as a result of mutations. The least severe form of beta thalassemia is beta thalassemia minor, where there will be a beta normal / beta positive finding. Beta thalassemia minor is characterized by elevated red blood cell count. The patients are typically asymptomatic, and the findings would show microcytic hypochromic red blood cells and target cells, classically, target cells. Hemoglobin electrophoresis of beta thalassemia minor shows slightly decreased hemoglobin A with increased hemoglobin A2, which is 5%, normal 5%, and hemoglobin F, which is 2%, because normal is 2%. The most severe form of beta thalassemia is beta thalassemia major, where there's a beta naught. Beta thalassemia major does not affect the fetus, but after birth, strong hemoglobin F, due to A2 gamma 2 at birth, provides momentary protection. But a few months after birth, when the baby's making its own red blood cells, the baby will finally become symptomatic. In beta thalassemia major, tetramers cause red blood cells to cluster and get damaged, which impairs erythropoiesis and causes extravascular hemolysis, or the spleen, to remove circulating red blood cells. Massive erythroid hyperplasia that follows causes the hematopoiesis to spread into the skull, and you'll get this classic sort of mohawk appearance on imaging, where reactive bone development causes chipmunk faces. There's a crew-cut appearance of the skull due to hematopoiesis in the skull itself, and extramedullary hematopoiesis with hepatosplenomegaly, right? The liver and spleen are getting bigger because hematopoiesis is taking place in those organs. Patients with beta thalassemia major are at risk due to parvovirus B19 infection of the erythroid precursors. Frequent need for chronic transfusions increases the risk of secondary hemochromatosis in beta thalassemia major. The histology of beta thalassemia major will show a blood smear with microcytic hypochromic red blood cells with target cells and nucleated red blood cells, as you can see here in this image. You see all those target cells? Electrophoresis of beta thalassemia major will show little to no hemoglobin A, with elevated hemoglobin A2 and hemoglobin F. Woo! We made it. Great lecture. That one's very big to know. Proud of you. Good job. You made it through. Make sure you know all of that because there are so many questions that come from it, right? But you did it, and I'm proud of you. You know it. I know it's in your mind. See you later, all right? Ciao.